Hi everyone, my name is Sarita, and on behalf of the Thrive team and the peer navigators and staff at the Positive Health Services Clinic, it's my pleasure to welcome you all to Home Care Our Way. Please note that this session is being recorded. To start off, I'd love to ask my colleagues Claudette and Angela to open our session with a land acknowledgement.
My name is Claudette Cardinal, Wapokmani, and I'd like to acknowledge that we're on the unceded ancestral traditional territories of where I am, Squamish, Tsleil-Waututh, and Musqueam.
Angela Thompson from Lower Mainland, Stolo Nation, First Nation, peer navigator for Positive Living, AIDS Vancouver.
Thank you both so much. May I please ask my team members to turn on your webcams if you have them so I can introduce everyone? In conducting this project, we've had the pleasure of working with a diverse multidisciplinary team, some of whom you can see here, and I'll just ask you all to wave if you can. We have Donna and Shayla from the Positive Health Services Clinic. That's Angela, Gary, and Hesham from AIDS Vancouver, they're peer navigators there. Antonio, Claudette, Patience, and Cheryl, who are PRAs from the Thrive team. And I have Anna, who's the Thrive Research Coordinator on the line as well. And I'm Sarita, I'm also with the Thrive Research team. Thanks, everyone. We have a packed agenda this hour, so we won't have a chance to do introductions for all the attendees today, but please feel free to use the chat function to introduce yourselves. We know from reviewing registrations that we have quite a few care providers on the line. So on behalf of the team, we wish to thank you for all of your commitment to your clients and communities. We hope that some of our findings and the conversations that this work might spur will be helpful in your work going forward. So the story of how we got here today begins with the Thrive team looking for new methods to recruit study participants. Thrive is a research study focused on older adults living with HIV in Vancouver. Our team sought out the expert advice of Hesham Ali, knowing that his role as a peer navigator at the John Rudy Clinic at St. Paul's Hospital would help connect us to more study participants. As anyone who's familiar with Hesham knows, when you find yourself talking to him about any challenges, you're likely to walk away with solutions and probably some research questions and an idea for more projects, which is exactly what happened with us. In the process of trying to help us connect with more study participants, Hesham shed light on a population we weren't working with at all, older adults living with HIV outside of Vancouver. Suddenly, our attention was shifted to Fraser Health with all of its unique challenges and important strengths. Our study mandate did not include Fraser Health at the time, but we strongly felt we should find a way to learn more about these issues and see if any of our work with the Thrive study could support our partners and our new friends at Fraser Health. Hesham kindly connected us with his colleagues at Positive Health Services to start these conversations. We assembled a team to submit a project proposal to the BC Support Unit to secure some seed money and build a little bridge to Fraser Health. Our project is titled How's the Care Out There? Exploring Home and Community Care Needs of Older Adults Living with HIV in the Fraser Health Authority region. The team was assembled and the grant was written all at the start of pandemic restrictions coming into place, and this group has impressively conducted the entire project virtually. Over the past 10 months, the team, primarily led by our peer research associates, assembled an inventory of strengths and gaps in home and community care services in Fraser Health. They developed an information postcard about home and community care services, and they translated it into Punjabi, Mandarin, Arabic, and Swahili. Finally, they've conducted a survey about services available to older adults living with HIV with community-based organizations. I'll hand it over to my colleague Gary, who will present the next set of slides.
Thank you, Sunita. My name is Gary Leasing, pronouns he and him, and I am a peer navigator working for AIDS Vancouver, and I work out of the Positive Health Clinic in Surrey. What are home and community care services? HCC services are to help people receive various types of care at home or at care facilities and to live as independent as possible. There are 4 types of services. First, home support is for people who need help to live safely in their homes. Services may include home IV services, meal services, medication management, and personal or wound care. Next is community nursing and rehabilitation services are for people who needs help to get better after a surgery, a hospitalization, or injury. As well, assisted living, there are housing plus rehabilitation health services. If you are relatively independent but need help with meals and personal care. And finally, we have long-term care is for people not able to live at home and need specialized care because of chronic physical or mental health conditions. Next slide, please. The survey. In the summer of 2020, peer navigators like myself contact community-based organizations and aid service organizations in Fraser Health's region by phone and email. The survey asks about the services they offered, the population demographic itself, and challenges or barriers, and gaps in services. By October, the surveys were tabulated and certain themes emerged as a result. So before I introduce the next presenter, this will be a really good time to do a poll. Next slide, please. Poll number 1. According to the last 2020 report by the BC Centre for Excellence in HIV and AIDS, there were 6,548 older adults living with HIV in the province. How many older adults living with HIV do you think are residing in the Fraser Health Authorities? Your options are around 1,000, around 1,100, or around 1,300. You can enter your answers in the chat function on your right-hand side. Can we move on to the next slide, please? So the answer is 1,373 people, which is 21% of older adults living with HIV in the province. Thank you. And I would like to present the next presenter. His name is Hashim Ali. Thank you.
Thank you, Gary. My name is Hashim Ali, and I'm a peer navigator at AIDS Vancouver. I work primarily at the John Rudy Clinic at St. Paul Hospital, but also at Positive Health Services in Surrey, clinic in Surrey. It has been really a pleasure working with Sarita and the entire team on this project. And now we'll just go through some of the data we tabulated from the surveys of community-based organization and aid service organizations. Demographic-wise, a substantial percentage, 25 to 50% of clients served are older adults for these organizations. And that, of course, will include older adults living with HIV. Not surprisingly, food security, housing, and transportation are some of the main challenges that came out of the survey. Transportation in particular is an issue. As you can see from the map, Fraser Health extends from Burnaby to Boston Bar, so it's a huge geographical area. And most organizations have some sort of transportation support, in addition to grocery program, housing outreach, and other services offered. Also, one of the findings is that most services are concentrated in the Surrey area or in the city of Surrey itself. So they tend to be Surrey-centric. There are, of course, organizations or agencies working in different municipalities within the Fraser Health Authority. But I think there's a need to expand services, especially in the Tri-City area and in Langley. Again, there are organizations working in this outside of Surrey, but there's definitely a limited options out there. Another challenge is the language and cultural issues to access services, including healthcare, of course. So as you know, Fraser Health region is home to a diverse ethnocultural communities. And here we have a couple of polls. So next slide, please. Okay. So what are the languages in addition to English that are spoken widely in the Fraser Health region? If you can guess some of the languages, if you can add that to the chat box on the right of your screen. And I think we can have the next slide, please. Okay, so predominantly we have Punjabi, Arabic, Hindi, Chinese, Swahili, and Tagalog. These are the kind of 6 language groups in addition to English that are widely spoken in the Fraser Health region. There are, of course, other languages, but these are the main ones. And if I can go to the next slide. Okay. So this is the second poll. What percentage of people residing in the Fraser Health Authority region for whom English is not their first language? So those are folks whose native tongue is not really English. And if you can guess and add that to the chat box.
If anyone would prefer to raise your hand, we can also unmute folks if you want to respond.
Yeah, thank you, Sarita.
No problem.
And if we can go to the next slide for the correct answer. It's actually 44%, which is a huge percentage. I mean, coming almost to 50% here, which means there's an increasing demand for interpretation services, but also to have cultural safety protocol in place, because language barrier are also linked to cultural barriers to accessing services. So as you can see, the need is there to have interpretation services and also culturally sensitive or culturally appropriate services within the healthcare system. Next slide, please. So the languages identified as in the next the previous poll were Punjabi, Hindi, Chinese, Arabic, and Swahili, and we actually did a poster or a handout in these 4 languages. In these 5 languages, and which actually were distributed within the Positive Health Services Clinic in Surrey, and they are available in the resource section at the very end of the presentation here. One thing to note is even though spoken English is widely understood, but within different English-speaking countries, different things mean, the same thing could mean different things to people. So next slide, please. So even though English is not a particularly hard language to learn, but it's full of kind of particular or oddities. That fruit on the right side of your screen is pineapple, which is actually neither. It's neither an apple nor a pine, and in every other languages, including non-Indo-European languages, it's a variation of the word ananas. So that's kind of very special to English, calling pineapple. The other thing is that, if an English person talk or say something, you may misunderstand what they say. Usually in formal English, if somebody says to you, this is a brave proposal, you might think it's courageous of you to have this proposal, but what they actually mean is that you're insane to even suggest this proposal. Next slide, please. So there's definitely a need to have interpretation services that are in context versus literal translation. What we have found is that most people prefer interpretation services over the phone. It reduces kind of, exposure or outing in the community. If you are within a very small cultural community, you may be afraid of outing yourself as someone living with HIV. There are also some challenges with languages in general, expressing new ideas, new social norms. French, and German and Arabic, you need to conjugate verbs in either a masculine or feminine form, which could be a challenge for someone from the trans community, for example. Even if you try to use the plural form of things like we use in English, like they or are, that actually will not work, because in French and Arabic you actually need still to conjugate the verb according to masculine form, even if it is in a plural form. Arabic also have some challenges. Again, they're not really barrier, they're just more of a challenge because it's heavily influenced by the text of the Quran, which is a religious text. So if you're a person who is an atheist or a non-believer or a member of the LGBT community, that could be a bit odd to kind of modify your language to be respectful for everybody. I tried that myself with that, but it would sound odd. So I would rather just go with the the spoken language as it is, and explain that this is how we talk, and there's no disrespect meant by those expressions. So culturally sensitive interpretation are definitely need a special training, and especially like technical training when it comes to, like, say, law or healthcare. Just an anecdotal evidence here. I once was with a patient who spoke Vietnamese and he actually spoke English, and we were with a specialist, and the specialist mentioned that but there were interpretation services over the phone as well. And the specialist mentioned that the medication should be taken either morning or afternoon or evening, and the patient could choose whichever time worked for them. And afterwards, when I was talking to the patient, he mentioned, "Oh, I just should take it in the morning and evening." And I said, "No, you should only take it once a day, either evening or in the morning." And of course, I had no idea what the interpreter over the phone mentioned, or like how they interpreted that particular instruction. Next slide, and I believe that's my colleague, Angie.
Home and community care challenges. So the language cultural barrier is more pronounced when providing HCC services. No cultural language specific long-term care homes, retirement facilities, which makes it difficult to access service and contribute to isolation. No home care challenges, services geared to LGBTQS, older adults, people living with HIV, ethnocultural communities, lack of healthcare coverage, understanding, especially when it comes to new immigration refugees. Next slide. There are no easy to follow steps to access HCC services. Often you need social worker or peer navigators to assist the home assessment and follow-up. There is a need for improvement, cultural safety, and the HCC services for non-English speaking population, LGBTQS plus people living with HIV. There is a need to overcome cultural barriers to assessing long-term care facilities. Referral and assessment process need to be simplified and made accessible to different communities. Greater integration services between Fraser Health and Vancouver Coastal Health is needed. Next slide.
And it is poll time. Again, lovely participants. The question we're asking is, what do you think are the main barriers for individuals from ethnic communities who are trying to access home and community care services? Your options: language, lack of awareness, cultural or traditional differences, cost, or all of the above. Give it a minute. All right, next slide. The lovely answers for individuals from ethnic communities are all of the above. So whoever selected all of the above, you're correct.
Yes,
Next slide.
say all of the above.
Awesome. Next slide. I'd like to comment in regards to this slide. Loneliness was one of the main themes that came up during the community-based organization surveys that we had conducted, and especially true for specific cultural language groups, newcomers, adults, older adults living with HIV. Stigma played a huge role contributing to isolation. Some are reluctant to engage for fear of being outed in their communities, and there's fewer resources available for within Fraser Health Authority and in the Fraser Valley, and plus outside the major urban areas. Their services are lacking, and due to COVID, that exacerbated the situation. And I would like to call on my colleague Patience for, that time, it's poll time again.
Oh, hi, my name is Patience. Like my colleague has said, it's poll time again. What is the percentage of people who say that stigma prevents them from accessing healthcare services? You can choose from 20%, 30%, 40%, 60%. Yeah, just choose among those and come up with an answer.
We have one guess for 60%.
Come again?
One person has guessed 60%.
Okay, next slide, please. What is the percentage of people who say that stigma prevents them from accessing home and community care services? According to the BC Stigma Index, it was 30% in 2017. Types of stigma: we have perceived stigma, beliefs about how others view something negative. Anticipatory stigma, anticipating negative behavior, discrimination, prejudices based on association with different disorders. Treatment stigma, stigma associated with getting treatment for mental illness or treatment itself. And that is a huge one. You find that people, most of them are in denial. Some of them cannot even reach out and get support. Experience stigma, the actual experience of negative behavior based on association with different disorder. Internalized stigma, holding negative views about oneself based on negative association, different disorder. I went through that when I was a newcomer in Canada, and that is common also in our African community. Next slide, please. Resilience and community building. We need to build resilience in order to respond to stigma. And how can we do that? You cannot do it alone. You need to engage yourself in the community. This should be part of community building. Collaborating with different CBOs is important to build a strong foundation to withstand stigma. Stigma is like a killer disease. And most people who are experiencing stigma, they die silent. That's when we have to engage all of us as a community. Next slide, please. Cultural safety in African, Caribbean, and communities. Train healthcare providers to be aware of racism and discrimination and about the importance of confidentiality, respect, and dignity, which is very important because we have lost lives. People have been disconnected from healthcare because of racism, and it's huge. And most of the times, we don't talk about it. That's why people are dying in silence. More research is needed to document poor health outcomes related to racism and stereotypes faced by African, Caribbean, and Black older adults, especially in a community, in the African community. Older adults, they have fear and shame because of their HIV status, and they choose to hide. In my culture, they say a child who doesn't cry dies in silence. So that's what happens to newcomers when they come in Canada. They don't know the system, they don't know their rights. That's why they're dying in silence. Develop and evaluate cultural safe models of care for health services offered. Research to translate into policy of all levels. And research, most people are ignorant about research. I think it's time we come together, all of us, and also share the word about the importance of research so that people will engage. That's why the African community is left out all the time, because people they don't understand the importance of research. Tackling negative attitudes through education can help preserve older adults' dignity. Like when we have focus groups, it's important to engage older adults living with HIV and also reach out to them and also have outreach to support them one-on-one, because most of them cannot engage. Next slide, please. I think I'm handing over to my colleague, Gary.
Thank you, Patience. Thank you very much. Yes, stigma. So how does stigma impact Filipinos living with HIV? I've worked with many Filipinos who've shared their healthcare experiences regarding their anxiety to access healthcare services including myself, because of the overrepresentation of Filipinos in the healthcare sector. Culturally, we like to ask each other their last names. Example, getting blood work done or picking up medication in the community, there is a fear of being outed. And like other communities, gossip can be an issue. Filipinos living with HIV face internalized stigma because of the influence and doctrines of the Roman Catholic Church in the Filipino culture. Our culture has been colonized for 500 years. Topics like sexual health, contraception, or harm reduction practices, mental health, sexual orientation, and sexual identity are taboo and often not protected by the law in the Philippines. There's a saying in my community, crab in the bucket, which means we're all trying to find a way out of this bucket. However, there's always someone in that bucket willing to pull us down. So by saying so, it's really important for people living in HIV to have a good and better understanding about their rights. As well, build in resilience and also be part of a community. Thank you. Next, I would like to introduce Angela for the next slide.
Indigenous older adults living with HIV. So there's gaps of culturally safe of home care community services for Indigenous people living with HIV. Differences in provision and services, off reserve and on reserve. Social assistance issues, aging out. Aging out is they are on disability and they would, once they age out on disability, they go on old age pension. Oh, vice versa, sorry. Social assistance issue, aging out status disclosure, peer navigation, gaps in access and availability in different communities. There's a lot of issues with, say, I'm using as an example, Coastal Health. Their Indigenous people are sent out to Fraser Health to get their medication needs, and they also, the reason why is because they don't want to be outed as well. Next slide. The next presenter is
Claudette. Hello. Thank you, everyone. So this is just a rundown of what we as a team of Thrive have done with our interviews. They usually are 1 hour semi-structured interview. Our topic is home and community care experiences of older adults living with HIV in the Vancouver coastal area. It is peer-initiated contact, so us peers, myself, Antonio, and patients, contacted participants. We also co-led with our lovely coordinator, Anna, and a peer researcher to do the interviews, and 7 were done in person between December 29th and February 2020, and to date, 18 phone interviews, July to December 20th, 2020. And I'd like to turn it over to my colleague, Antonio.
Thank you, patient. With the intention just to show these numbers, these results are just to provide you information how you can obtain this information from Fraser Health if you agree to pursue to interview participants in Fraser Health. So these numbers belong to Vancouver Coastal Health. So we interview 14 participants. They say they apply for home and community care services, but also we realize in our path just to interview them, we realized there were people, they say they don't get the home and community care services, but they were denied. So these people are just here in this table in the right, no HCC. We identify them as no HCC. And they didn't get the home and community care services. They were denied, many of them, when they went to the Ministry of poverty and social development, and the front desk, the greeter, said you don't qualify. So, but we want to hear from them also how they experience aging with HIV, how they experience with the stigma in HIV, and inside and outside the health sector. So that stories were documented. Next slide, please. So for our analysis, we developed a code book for a team analysis. This process was developed by team participatory process. All of us were interacting each other, and by consensus developed this code. And I will show you later some examples. The code design included 27 main codes and 79 subcodes. And we used a software called NVivo to doing all the transcript analysis and make some explore cross-tabulations, data analysis. And the coding for NVivo was doing in two parts. One was doing it, the whole team was doing together specific transcripts. And there was another step that we were doing individual analysis. And then we share our experience with other peers, and that's why the collaborative process started. So there was a combination between the peer researchers and the project coordinator. Next slide, please. So for we have here this code, main code that NVivo call parent code, is we call HCC referral. HCC referral was divided in the following subcodes or NVivo called child code. There were challenges, extra support following an acute incident, lack of information, and self-referral. We asked this question: could you tell me about how you were referred to your home and community care services?
R1, when I was in VGH, they were going to release me, and I was going into a nursing home. They asked me for my preference. The only place I could think of was Central City Lodge. So I told them Central City Lodge. Then they put me on a fast track, and I ended up at Dr. Peters Center for exactly 6 months. Then a room came up in about 6 months, and they moved me down there. I've been there for about 3 years. White male.
When we asked another participant the following question: are your medical team and your medical team was supportive through this process, from the process?
Very supportive. They moved me to healthcare organization, retracted, and then from there I was assigned to a home care provider. I forgot what they call it, sorry, and then they came and assessed, and then I was appointed somebody else, and then they came in based on her assessment, and then they came in and decided what was needed to maintain my independence.
And was there something that made the process at applying easy or difficult?
If I didn't have a team behind me to help me navigate, I probably would have a harder time doing it.
Next slide, please. So this other code is about Hcc Quality of Services. And this is the parent code, and this parent code was divided in the following children codes: comfort with Hcc services, complaints about services, flexibility on home and community care workers, fundings, and home and community care trainings. When we asked the question, could you please tell me about your assisted living facility or home community care services? What's going well for you there, and what you would like to change?
R2. Well, they have the native doctor come in once a week, so that's no problem. And they book all of the appointments. I've been able to get my dentures, my eyeglasses, and everything since I got there. But they'll book everything for you. They'll take care of all your medication needs, so there's always transportation.
And a second respondent, because I've had people that don't turn up, but nobody called me. I have an appointment to go to, and I'm relying on them to get there at a certain time, and nobody turns up. So I don't have service that day. Or when they turn up, I'm already halfway to the hospital. But they still get paid because they did turn up at my door. So for them, it's like, oh, the worker should call you and not the office call you. So there's a lot of stuff that is happening with the home care that I don't think they are training all their staff. End quote.
Thank you. Next slide, please. The next parent code is assessment, a home and community care assessment. And this parent code was divided in the following children codes: denial, flexibility, healthcare entities, making changes, paperwork, quality and satisfaction, wait list, and wait times. When we asked the question, how well did the assessment identify your needs?
Just lately, I've had 2 back surgeries. I came out of BGH hospital. On the 2 occasions, they had occupational therapists testing me out for information on what I needed for home and stuff like that. That's the kind of support I had before I left the hospital. They did it on both occasions, but first one, they basically slugged me out. And it was December 30th before New Year's. As long as I could walk, I had parents that were standing there to take me home. They were suggested that it was okay, that I was going to be okay. That was their way of sending me because my parents volunteered the company, end quote.
Respondent 2. So my assessment was done basically through an interview. The lady came to my home and she looked at the place and asked me questions about what I needed. Things like, do I need any medication preparation? Do I need cleaning services? Do I need help with making lunch? Those type of things. So we went through and decided what it was that I needed at this time, which was basically some support services around cleaning. That's basically what my services are right now, end quote.
Thank you. Next slide. So now we will pass the control of the presentation to my colleague, Anna.
Thank you, Antonio. Thank you. So this is just to conclude our presentation. We are sharing some of the resources here that were developed by the team. And here on this slide, you just have a picture of the postcards or flyers, 1 in English and 4 translated into simplified Chinese, Swahili, Arabic, and Punjabi, but they're available for download if anybody is interested on the Thrive website. And just some other resources that we're hopefully going to finish by the end of our project. The data and all our analysis is completed as far as inventory of strengths and gaps of the home and community care services, and also the results of the community-based organization survey. So they are all ready. We just hope to organize them in a way to present them and publish on the web. And also a peer-led brochure for the Positive Health Services Clinic was completed by the team. And as it says here, it was peer-led. And it's just in the process of being reviewed and approved by the clinic staff and manager. And then hopefully it will be also translated into the same languages that are most commonly used in the Fraser Health Authority by the patients of the clinic. And I believe now we are ready for your questions. Here's just some of the contact information on how to reach our team, both the Thrive team at BC Centre for Excellence in HIV/AIDS, and also the ACPNet Afro-Caribbean Positive Network, represented by patients, and the Positive Health Services Clinic. So thank you so much for your attention, and we hope that you found this presentation useful, and we would love to answer some of your questions.
Anna, before we start the question part, I would just like to acknowledge and express, not just on behalf of myself, but the entire team, our gratitude to you. You have been truly the backbone of this project, organizing us, dealing with technology that's really hard in this time of COVID, getting our meeting in order, and also documenting in a coherent way our sometimes chaotic discussion within the team. So I would like to thank you, and I know I'm going to butcher the Ukrainian language here, but thank you very much, or to be in compliance with language law. Merci pour ton travail acharné. Merci.
Oh, Hesham, thank you so much. I really value those words. You caught me off guard here with the Ukrainian as well. Thank you. It's been my honor to work with each one of you. You're truly a very vibrant and a very, just a very passionate team that's devoted to the cause. So it's been really a great time.
Thank you, Hesham. That was so beautiful, and it was perfectly said. Anna has been taking all of the eggs that are breaking and ingredients that are chopped up, and she somehow makes omelets every time we meet. And really appreciate it.
Oh.
Yeah, this is the only sad thing about this webinar, is that it's bringing our project to an end. But we're so glad to have folks on the line who are, we consider our partners in this journey, because we definitely hope that some of this work will contribute to the work that you do. So we're really excited to hear from you if you think it's relevant to your work, some of your stories, any questions you have for our team here who's collecting this information.
I just wanted to say thank you to everyone for doing such a fabulous job, and I hope to see you all soon.
Thank you so much, Sarah.
It means so much to have you on the line and have your support today as well.
I think if anybody, no, I don't think that people can unmute themselves still. But if anybody wants to ask a question audibly, you can raise your hand and then the organizer can unmute you manually, or you can type in your question in the question box.
We have a question from William asking if we'll be getting the PowerPoint presentation slides.
I think so. The webinar is also being recorded, so it will be on the website, the recording of it. But we don't want to spam everybody with our presentation if you don't want it. But yes, if there is an interest, we can certainly share our slides.
Wonderful. And what website is it going to be posted to, Anna?
It would be posted on the Thrive website, but on the page within the website that says special or other resources. But it's right here. This is the first link here. So we can do both things. We can send our slides, and we can also just send the link to the web page where the webinar will be posted.
Thank you, Anna. I hope that that works well for you, William. He says thank you. That's perfect.
Yeah, and the postcards, they're downloadable, and of course they are available for any community-based organizations for them to use in their work. That's why they've been developed.
That's great. And I have William's email, so I'm just gonna grab that, and we'll be sure to share all of this with you, William. I'll ask our team members from Fraser Health, what do you feel are the best next steps after having spent some time reviewing these issues with us? Is it last week when we were doing the webinar, someone was asking if there's plans for further research or if we feel like we know enough to suggest something else? And I'd be so happy to hear your thoughts on that. I'm getting a lot of thank yous and great presentation comments. I have another comment here. Thank you, Thrive team, for this incredible presentation. It's difficult to get so much done virtually, and I'm so impressed that the team worked so well and led this project with such passion. Well done. You're all superstars. From Nilu.
Thank you, Nilu.
And William was asking if the webinar last week was the same presentation as this week, and it was. My toddler wasn't crying in the background of last week's presentation. That was the only addition today. Just for the recording.
That makes it more special and more realistic, because that's how we've been functioning.
Well, just to jump in and answer my own question, I hope that we do have some opportunities to work together again in the future with friends at Fraser Health to put some of our findings into action. And we're always open to partnerships for research projects, and I want to put that out there to folks on the line and to our team who we've been working with. It's been really lovely getting to collaborate with you, and we've learned so much. And there's so many unique challenges in Fraser Health, but we also learned about all of the incredible strengths in the community and incredible programming and passionate frontline work that's happening. So it's really been a terrific learning experience. Lots of fun.
Yeah, it's patience here. Like what Hesham has mentioned, thank you so much, Sarita and Anna. It's such a pleasure working with you, and also I feel so blessed working with you in research. I also had a negative attitude when it comes to research, and it's a very good opportunity now to spread the word to my team, to my community, the importance of research. And it has really opened my mind, my eyes to see the importance of it. And also, I'm so blessed to work with people who value respect and for treating all of us with respect. I really appreciate that. Thank you so much. And also for the participants, and I really appreciate each and every one of you. Thank you.
Thank you, Patience, so much.
You're welcome.
I've been unmuted again. Sometimes This has happened with technology a lot, although I don't think it's a conspiracy to silence me sometime, but anyway. I would like also to echo patients' sentiment. And yeah, it's been great working with everybody. It's going to be hard not to have those Monday meetings to organize this project, but hopefully in the near future, we'll have another grant to work further into more details at home and community care support within the Fraser Health region. Thank you.
I too echo what my peers have mentioned. It's like, now what do? We have to find something to keep this going. So I just want to echo what everyone is saying, and thank you all for being present and attending today.
Shayla here from Positive Health. I just want to say also thank you for remembering Fraser Health, because we sometimes feel a little bit forgotten, but this is a great start to hopefully some future work. And thank you, Hisham, for remembering us out here to start this whole project.
Always, I've always been passionate about extending everything to Fraser Health since I live in the region anyway. So
yeah.
I have a self-vested interest in that.
But it's great, because sometimes I think, yeah, we've kind of forgotten out here.
And this is Antonio here. I'm going to say that thank you, Hisham, for the time we met for a few minutes, just talking about how to interview participants in Fraser Health, and that's where this project started.
And this is Gary. I just want to comment that this project was a great project because it gave us peer navigators a really empowering opportunity to get to know lots of the community-based organizations out there in the Fraser Health region, and getting to know what type of services they offer. One of the things I would like to wish is, like, in the future, among all these community-based organizations, if there is a way for them to maybe cross-pollinate and share their services among each other to address particular issues that an individual may be requiring. So that's just a question I sort of think of sometimes. But yes, I was really excited about this project when it was proposed, and I was very excited to take part of this project because I know there was opportunities to connect with people out there. So thank you very much to Thrive, Hisham, and the team.
Yeah, that has been my prayer for many years, to have such a program in Surrey. There was a time I nearly moved to Vancouver because of all what was going on in Surrey. I'm highly blessed to find that we are working together in Surrey as a team. I know a change will happen. Thank you.
Thank you, everyone, for your lovely thoughts. And we're getting lots of thank yous in our question chat box as well. So thank you to all the participants who took an hour out of their day to chat with us and hear about our project. We really appreciate it. Please note down our contact information if you want to reach out. But it's the end of the hour, so I'm going to formally close